Oh, hey, Chris.
Hey Chuck, how are you?
Oh, pretty fair. What's up with you?
Oh, not much. It's a beautiful Saturday in St. Louis, and I came in to round and see a couple of inpatients. But these were consults that other partners had asked me to see, and I figured if I was coming in to round, might as well come in and do a podcast.
Yeah, you have a quiet office to work in, which it may not be the case in your home.
No, definitely not. And you were kind enough to wait around while I finished walking around the entirety of our hospital. Classic attending fashion, got lost while trying to round on my own.
Well, we're trying, as you know, we're trying to set up a rounding policy for the hand division. And one of the prerequisites is that we have whoever the resident or fellow is who's in the hospital is going to have to hold my hand and take me to the patients, which I never thought I would be that attending, but I am absolutely that attending.
I didn't even know this part of the hospital I went to existed. But I did think there is a good cafeteria in the area, but I had to rush back so we could record the podcast. But I will tell you, there is nothing as glorious as a Saturday morning breakfast or brunch in a hospital cafeteria when they have the good stuff, which to me is the chicken and waffles.
Yeah, well, the only thing that makes it more glorious is if you've been up all night, you're having your chicken and waffles before you go home to take a nap. But that's not
Yeah.
probably not happening for you.
No, no. So no chicken and waffles. The other thing that hospital breakfasts are great for are crispy hash browns, which the children's cafeteria usually delivers on that. So usually when I get there, it's after my first on-call case, and I'm looking for something to do.
I love it. I love it. So family's good? Spring is here or seems to be here? Is your family optimism about the world rising like my own family's?
Yeah, family is good. Morale is holding steady. We've been to the same lakeside community within 60 miles of St. Louis 4 or 5 times in the last year. We marked our 1 year anniversary of the pandemic there. But my kids are young enough where they just honestly they have a good time just finding a body of water. And my son and I went fishing last weekend and we each caught a fish. So that was big. I made a lot of good food at the lake house, drank some good wine. So it's been good. I needed those days to recharge. So I think I like the 5 day weekend better than the entire week off, to be honest with you, because I feel a little less frantic when I get back. I don't know. What do you think?
I've struggled to figure that out. I do like a 4 or 5 day weekend. It brings a different mentality than the full week off. I'm about to take a full week off. I've often thought that I should take 2 weeks at a time because it takes me a couple days to ease in, and then I get nervous about coming back and all this gonna I'm going to face, which is just a lame mindset, which is mindsets is the topic of our discussion today. Yeah, I like the concept of a 4 or 5 day weekend.
I don't do it enough, and I guess the opportunity never really presented itself that much prior to the pandemic because we were always trying to take bigger chunks of time off. But maybe that'll be a legacy that sticks around.
Do you miss the lack of travel for our work?
Kind of. To be honest with you, it was always a nice way to unplug and recharge and come back. I don't miss the fly into Chicago for a committee meeting deal. But I do miss, the time away to like go to a meeting like the Hand Society, for example, and like run into people and sit down and have coffee or whatever and catch up with people. That I do miss because it's just not the same over a screen. It definitely is not.
I think you're right. I think it's be interesting to see which committee meetings come back for in person versus stay Zoom. But I am one that sometimes has historically gone to meetings where I'm busy doing lots of stuff, and I haven't historically taken advantage of the opportunity to sit down and have a coffee, as you say. I think I'm going to be a different person at the meetings when I have the luxury of going back to them.
Now, were you ever the type of person that tagged on an extra day? Like, say the meeting was in, I don't know, San Diego. Did you tag on an extra day or two to, not be at the meeting and enjoy things?
Never. Um, for a couple of reasons. One, Talia and or the kids never came with me. Um, and second of all, I thought my obligation in the meeting was do a great job at the meeting in whatever capacity that was, learn what I could learn, and then not only not get behind at work, but catch up, whether that be some writing or the like. I always felt guilty if I went and had too much fun, which is a lame way to think about the world. But I felt like if I came home further behind than when I left, it wasn't fair to my family, which I don't know if that sounds crazy or not crazy, but it's just the way I used to think about it.
Now, are you the kind of person that can work on an airplane? Because, when we had Jim Chang come a few weeks back and he talked about his stack of work he would bring on the airplane, I was like, I cannot work on an airplane. The ergonomics are awful. I end up getting a headache. So I'd rather just read a book, sleep, and do that on an airplane. And I do love myself a little hotel room work. I'll be honest with you.
I, for the same reason that Jim said, I love the airplane. I work from the minute I sit down to the minute I leave. And I will never forget as the Bennell Fellow flying to Australia and, long flight. And I thought it was great for my efficiency.
You would, Chuck. You would.
Judge me if you must.
Oh, I can see our generational differences. They're very apparent right now.
Yes, they might be. Um, Super interesting.
Well, we've had some great reviews. I'll take a minute to read one, and then we are going to draw for a mug, which I know that some people listen to the beginning of the episode just for that. Hi, Paul Inklin. So this is a review from Dawn Bean. She left a 5-star review on iTunes, the only kind you guys are allowed to leave. I'm an occupational therapist in Mississippi studying to take the CHT exam. I've worked in hand therapy for over 8 years and have craved a podcast such as this. Not only are y'all funny and a joy to listen to, but your topics are a great way to enhance my learning from a surgeon's point of view. Thank you for creating such an interesting and valuable podcast. Don Bean, OTR/L. Somebody will have to tell me what that means one day, comma CLT.
Don, that is super nice. And, those are the words that sustain these efforts on the weekends. And so we are grateful that you enjoy it. No one craves in my house, at least my talking. So I'm glad someone might a little bit at least.
And I've totally mentioned this before. I think my son thinks it's totally normal for a dad to have a podcast. So he just walks around telling people, "I have my dad's podcast," or whatever. They're like, "Wait, you have a podcast?" I'm like, "Oh yeah, got a podcast." But Don, yes, thank you for those comments. They sustain us, they keep us going. Shout out to all of the hand therapists that are listening in our community. We are excited. We're going to be recording a live episode of The Upper Hand at the ASHT meeting. So thank you to Nora for the opportunity to do that. We're really, really excited about that. And that'll be in your meeting in October. So Chuck, it's time for a mug drawing. And you promised last time that you would go high on the numbers.
Oh,
So,
for sure. I'm going high. Number 79.
okay. This is somebody at UCSD. And the first portion of the email address is AKORDAHI. So if you are that person at UCSD, please send us an email at handpodcast@gmail.com so you can collect your mug and let us know. Please take a picture and send it to us. We got a great picture from a recent former fellow who helped us in our virtual interview day. And I think the only reason he did it was to get an upper hand mug.
It's a good reason. It's a good reason. These are limited, quite limited edition. And, we're proud of the mug, just like we're proud of the podcast.
That's right. I told Chuck that we were trying to transfer the mugs. I still have to bring them over, by the way. And he was like, "Yeah, I haven't given any away." And I'm like, "All right, that's fine. My dad wanted one. I didn't give one to my dad." You nicely replied, "You should give one to your dad."
Yeah, for sure.
For
All right. Well, I am looking forward to the ASHT meeting here in St. Louis and in early October. And I hope those therapists who are listening are all planning to come. And it will be super fun to do a live podcast. So that will be great. And that is highlighted on my calendar for sure.
Yes, fingers crossed that it can be in person, and I think it'll be a lot of fun. And I think the organizing team has done a great job with getting everything together. Now, Chuck, do you have an interesting case?
Yeah, I do. So this will bring up a couple issues. I value the physician-patient relationship. And for that reason, I like to see every patient I operate on before the surgery in clinic. But clearly in our worlds, that cannot happen. Obviously, there's the trauma patients that are urgent or emergent, but there's also the patients that may see one of our partners. And then I get a call about it or I get a text about it. I review the x-rays and I do try to call those patients and say, "Hey, here's what's going on. And I think you need surgery. Here's why. I'll meet you in the preoperative area." And that's fine. And I think patients are appreciative. I try not to make them come back to the office. And um, I think I probably should take a little more advantage of the opportunity to do a video visit. But in general, I just meet them in the pre-op area and everything's fine. So I had a case recently of a child with a proximal phalanx fracture. And, mom was a little vague about when this happened. And it was kind of portrayed to me about 10 days ago. I was like, okay, and the x-ray looked fine. I didn't see any healing on the x-ray, but we all know x-rays can be deceiving. And it was a subcondylar fracture. And so went to the operating room and I was working with a fellow and I'm like, all right, go ahead and reduce it. And an effort was made to reduce it and it didn't go anywhere. And then I gave it a shot. I'm like, come on, this is not that big a deal. I like
I can only imagine the number of F-bombs that were dropped during this effort.
Well, I popped out my chest and said,
Yeah.
let me show you how to do it. And nothing happened. Classic. And so then, those fractures are dangerous and it might be a good episode for us to discuss, but because the vascularity of that distal fragment, the distal aspect of the proximal phalanx or middle phalanx can be, vascularity can be tenuous. And so I tried to do a little joystick technique, no success. So ultimately I used a technique that Peter Waters described originally. Roger Cornwall in Cincinnati published a paper on it. It's called basically osteoclasis, where you go from dorsal, use a KY to break up the healing and then lever the fracture back in place. And thankfully that worked, because opening those fractures is a recipe for risk of vascular issues. And so it ended up fine, but it just brings up the issue of, obviously we trust our patients, and mom certainly didn't intentionally tell me the date of injury was, incorrectly, but it was a little eye-opening. All's well that ends well, but it did raise my eyebrows.
So, do you think you would have gotten that information if you had seen them in the office the day before? Like, say your partner had emailed you and said, "I can't do this. Would you mind seeing them?" And then you said, "Well, come into the office. I operate on Wednesdays. Why don't you come to the office on Monday? We'll just chat."
I think I probably would have. I mean, I like to be cognizant of the stress that patients and families are under, probably more so when it's the parent of a child about to undergo their first surgery. And so I'm not sure we have a great interaction. I mean, to me, it always seems great, but I think parents are thinking about a lot of things. And most of the time, they're not really thinking about what I'm doing. They're thinking about anesthesia and those kind of things. So I do think it's a better environment, either on the phone, on a video chat, or honestly in the office.
Yeah, I guess I wonder whether I don't know, maybe it's something about me. I probably would want to look the surgeon in the eye before during a time before the holding area, if possible. So I don't know, maybe video does that. But I think there's maybe something to that kind of connection, but maybe that's just a little too cheesy or hokey.
I I like to think that would be true, but let's be honest. There's a cost to coming to our office, it being a copay, time away from work, especially when it's a parent. There's a hassle factor, and so much is about convenience and ease. And I honestly think I always offer when it's possible to come to the office. And most of the time, the vast majority of the time, they say, "No, I'm fine meeting in the office." When I'm talking to them on the phone, and they say, "I'm fine meeting you in the preoperative area."
It's interesting because I've had the opposite experience. When I offer the office, they typically want the office.
Huh.
So that's kind of weird. Maybe it's because of my youthful appearance and your old guy knows what he's doing appearance. They probably
That
look
is
you up online. They're like, yeah, that guy, full professor. He looks like he's been in practice for about 60 years. He probably knows what he's doing.
that is one of the advantages. There is no doubt. There is no doubt. I do not look youthful. No doubt.
Oh, come on, youthful inside, right? That's what they are, something like that. But that's a great topic. I think we should discuss that. There have been, I think, one of our fellows suggested that we do an episode on, all things pediatric phalanx fracture. So, Shobit, if you're listening, I think you're going to get your wish. But I think that'd be a good one to do next week.
All right, that sounds great. What are we going to discuss today?
So we're going to pretend like we're in business school again. This is probably one of our favorite hobbies to do. But we are going to talk about an article from the Harvard Business Review by Melody Wilding. And for those of you who actually want to read it, we'll put it in the show notes, but it's an article called How to Stop Overthinking Everything. It's on the HBR website. February 10th, 2021 is when I saw it published. And if you are interested, the reprint is H066LR. But I think this is a really interesting article about, how to stop from thinking about things too much, almost what's been called recently paralysis by analysis. So spending too much time stressing out, perhaps over the small stuff, or taking too much time before you make a decision.
Yeah, and let's face it, looking at you and imagining the audience listening to this podcast, we're all hand weenies, right? I mean, we revel in details, and a 10-degree improvement in PIP motion gets us excited. And so details and minutia, that's who we are. I think that puts us at a special risk for this overthinking.
So with the overthinking, Melody provided 5 steps to stop this cycle of overthinking, because this is something where, honestly, like, you talk about a case like a fracture, and you're striving for perfection. Perhaps you're striving for anatomic, or AFT as the kids call it now, um, and maybe you shouldn't be. Maybe by striving for too much, it's doing some damage, perhaps. So the first step here, and I'd love your thoughts on this, is to, number one, put aside perfectionism. So, for example, it says here, perfectionism can lead you to believe that if you don't make the quote correct choice, as if there was only right option, then you are a failure, or that you must know everything, anticipate every eventuality, and have a thorough plan in place before making a move. Trying to weigh every possible outcome in consideration is paralyzing. How do you think about this in the context of, say, a surgery where you're trying to fix a fracture, like that scaphoid that you described a couple months back, or this, this tough condylar fracture that you had to osteoclase?
Yeah, so let's be clear first that, this article was written for the business world, and we're extrapolating to the medical world. And it is very different. Before I answer your question, if it's okay, I want to define or use one of the definitions from the article, which I thought was good, which will kind of frame this, at least it did for me. The sensitive striver. And I think you're
Okay.
sensitive and you're a striver. So you guys picture Chris as a quote, a high achiever who processes the world more deeply than others. Studies show that sensitive people have more active brain circuitry and neurochemicals in areas related to mental processing. So I think many of us would think that we're sensitive and we're striving for perfection. Look, I think perfection is the goal in hand surgery, particularly. It has to be the goal. But the art of what we do is understanding when aiming for perfection can be too much. Does that resonate?
Yeah, I agree. In the surgical context, either whether it's indications, whether you strive for that extra 10 degrees of PIP flexion, whether that really matters or not, or whether it's intraoperative, whether you try to make that nerve coaptation absolutely perfect by taking down the repair that's already there, or whether you take out some of your fixation when you're fixing a fracture. I think that's the struggle that we have. And I think that, for example, like, say you're fixing a radius fracture, and we talked about this in the what's new section when we talked about the volar tilt. Say you get it to neutral. Do you take it? Because maybe that's enough. I don't know. How do you process that decision making?
And I do believe that is where, and not to suggest that I have all the answers, because Lord knows I don't. But I do believe that is where experience comes in, because it's not, you shouldn't accept something, at least this is Chuck's philosophy. You shouldn't accept something because you think it's going to be fine. You should accept something if you think it'll be fine, and the effort to do better could have negative ramifications, whether that's excessive time in the OR, increased risk of complications, other adverse events. I think, to me, it's got to be both. And that's just how I think about it. And it feels fair to say it, but I haven't ever said that out loud.
No, I think that's right, and that second part of it that you described, I think, is the linchpin there. Like, if it's gonna potentially increase the risk for more damage, if what you're doing does not work out, then yeah, I think that's when you perhaps set aside the striving for perfectionism and take what you know is going to be a reasonable result. I think that, what is that saying that's often muttered during fracture cases and on the trauma service? Don't snatch defeat from the jaws of victory.
It's true. No doubt. No doubt. I would say I watched a senior trauma surgeon be too meticulous. That was part of my training. I really think so. I think he was too meticulous in insisting on perfection. And I think that can be absolutely detrimental. But let me flip it around. One of the dangers for busy surgeons, and I assume busy therapists as well, is that, let's say you have a busy day, you're fortunate to have 2 rooms so you can bounce to increase your efficiency. And if you have a case that, I would say I can predict the length of my cases really well, almost across the board, but occasionally I'm wrong. And it is incumbent on me not to let time pressure change my assessment of what is acceptable or not. And I think that's a risk. And I think that probably, let's be honest, in real life, that probably does affect judgment, but we have to fight that.
Yeah, absolutely. You can't think that, my patient's in the room next door, or I have to go mark the next patient. So, this is fine. Um, and I totally understand what you're saying about that temptation, because it's natural. Like, when you feel like you might be rushed, you may not make the same decision. So, I think some of that, if there's going to be a case where you may have to make some intraoperative pivots, those are cases to put at the end of the day if you're structuring your lineup. But yes, I agree with you 100%. You have to try to avoid the very human temptation of letting those time constraints suck you in.
Yeah.
So one of the steps that they say here, I think that is most applicable to the surgical mindset. They say, to curb this tendency, ask yourself questions like, which decision will have the biggest positive impact on my top priorities? And I think that you think about your top priorities, right? So whether it's, restoring function and motion, um, if taking down that fixation will allow you to get a better outcome that will be meaningfully different, then yeah, sure, take down the fixation you have if you can do it without excessive risk. But if, changing that one screw or changing that row of fixation is not going to make a big difference on functional outcome, but will make you feel better about your x-ray, don't do it.
Yeah. I think that is how I think about it as well. If it's okay with you, I'll bring up point 2,
Yeah.
which is right size the problem. And I like what she says here. She says some decisions are worth mulling over while others are not. And so you need to put everything in perspective. And for me, and the author is talking about decision making. For me, I think about this, and I'd love to hear your perspective. For me, I immediately thought about complications or less than ideal outcomes, and it's not overthinking, it's becomes perseveration on a patient and their outcome. And to me, that's the biggest issue that some of us have, is that if things don't go perfectly, and let's be honest, things don't always go perfectly, how much will you perseverate over the problem, revisit it, think about what it could have been done differently? There's so many layers to that. I'd love to talk about that more, but at first I want to make sure that's what kind of your brain might have gone to the same thing.
Yeah, I think that's accurate. I think for that, you perseverate on things like complications. And also, like, I think it still comes down to the intraoperative decision making on whether to change a screw because it's a little long. For example, like I was fixing a proximal phalanx a couple of weeks ago with a resident, and one of the screw tips was a little long. But taking down that fixation could have ended in heartache. And I was like, you know what? We're going to leave it, because if we take this out and it falls apart when we try to put a different screw size back in, I am really going to be upset with myself. And that kind of goes with the solution that she describes here, this so-called 10/10/10 test. And so those of you nerve nerds that are listening, this is not the 10 test that Dr. McKinnon talks about. So she says here, when the prospect of falling flat on your face seizes you, think about how you'll feel about the decision 10 weeks, 10 months, or 10 years from now. And I think probably in a surgical context, I would say 10 days or 6 days, maybe even, since we're orthopedics, 6 days, 6 weeks, or 6 months. So same thing, like you're talking about this complication. Like, for example, somebody comes in and their incision doesn't look great. Do you prescribe antibiotics? Is it something where is there hematoma and you're concerned about having to go back to the OR? How are you going to feel about that decision, depending on how it goes in 6 days, 6 weeks, or 6 months?
I think that's fantastic. And I do like how you reframe that. Those are the right time points to think about our world of surgical, excuse me, outcomes. Um, And I think the point about right sizing the problem is important because let's be honest, when something is not perfect, there's benefit to reviewing it in your head, thinking about what went wrong, thinking about what you could have done differently. But there's also benefit to moving on. So you have to be able to achieve the balance. And let's face it, if you are if you're like most of us, I dare say all of us, when something doesn't go right, it really eats at you and can really be destructive almost. And so you have to find that balance where you learn from it, really learn from it, and then move on. And this is, I think about cases from 10 years ago sometimes. And those first couple of days or first couple of nights can be really tough when things aren't perfect.
Yeah, I think that we remember, and like most surgeons and therapists, I think understand we remember our complications more than anything else. And even though the complications are probably a small proportion of the number of patients that you treat, they have an outsized influence on your decision making in your practice. Like for example, the other day, I do a lot of ulnar transpositions, as do you. And the resident I was working with asked me, "Well, did you always leave a drain after an ulnar nerve transposition?" I said, "No, I didn't, until I had a hematoma that was really, really bad." And then I left a drain, and I think my hematoma rate has probably gone down. I feel better about it, but maybe it's an unnecessary step. But I think that the influence of complications can certainly affect your practice. And maybe leaving the drain, for example, is something that I'll feel better about in 6 days, 6 weeks, 6 months, or if it ends up being inconsequential, maybe I shouldn't leave the drain. But it's almost like trying not to perseverate on certain decisions, just saying this is what I do.
Yeah, and just for the audience sake, I don't judge Chris for leaving a drain, but I do not leave a drain. Here's a cheesy analogy, which I hope resonates with at least one person listening. So I played goalie in soccer in high school and in college, and God knows the last time I set my foot on a soccer field was pretty much when I graduated from college. And the interesting thing about that position is things go pretty well until they don't. And the keeper may be having a wonderful game until he or she isn't. And if he or she screws up, then the lesson I learned from that position is you have to forget quickly and get your mind right and get back into the game so you don't compound your error. And to me, in surgery, that resonates too. If you have a difficult surgery, you cannot let that affect your performance the rest of the day and for all the other patients you're taking care of. And God forbid you have a real complication, you have to address that complication, compartmentalize, move on, take wonderful care of the rest of your patients, and then you can step back and review that case that didn't go right. But I do feel like I learned from that sporting experience.
Yeah, like many things in life, I think that those formative experiences in sports or in other activities can really shape how you react and how you recover from situations like you described. I mean, there was, I think, I don't know how much of this is rumor or truth, but there's a rumor that there was a surgeon who used to walk these halls who, if they had a bad day and they had a complication, they would just cancel the rest of the day and say, you know what, the mojo's not there, we're done for today. And they'd have people flying in to see them and flying in to have surgery. But I guess if your surgeon's not locked in and ready to rock, then maybe you don't want surgery that day.
That was a new one for me. I'm not aware of who that might have been, but that's maybe taking it a little too far. But again, it's all about you. And if you cannot compartmentalize, maybe that is the best next
I
step.
mean, maybe that surgeon should have gone to the Chuck Goldfarb School of Goalkeeping.
I can offer that for a low, low price. I will impart my wisdom to any of you.
So the next point is to leverage the underestimated power of intuition. And I guess this is something where you probably don't need to have to convince surgeons to use their intuition a whole lot. But they cited this example of a study in which car buyers use only careful analysis were ultimately happy with their purchases about a quarter of the time. Meanwhile, those who made intuitive purchases were happy 60% of the time. And that's because relying on rapid cognition allows the brain to make wise decisions without overthinking. So, how often do you make decisions that you don't think about and you just go with your gut?
Well, I mean, there's been lots written on this. Blink, the book, which I have not read, but it was all about the intuitive choices we make all day, every day. And I'll back up a step before I answer the question and say that, we as, surgeons, therapists, whatever, are a product of our training and our mentors. And during those formative years, and honestly, really importantly, those early years in practice. And if you put all that together and add to it, learning the literature, gaining experience, seeing how your mentors handle things, those all together to me form an intuition background. And those are the things that allow you to make an intuitive choice. And so, of course, we have to use analysis. But the reality is, once you've been doing something for a while, that analysis brings your intuition in, and you can quickly reference those articles that have mattered to your understanding of a problem. I think the danger in just using intuition is that you can base your intuition on historical things and not stay up to date with the world as it moves on. So I said a lot there. I'd love to hear your thoughts.
Well, I think you hit the nail on the head with the how our intuition, is the data for our intuition algorithm, so to say, is populated by the early years in practice and by the years in our training. I'll give you and if you don't know why you're doing something, you're missing out. And for in training and then in the first few years of my practice, I would try to have a reason for why I did everything. Like, for example, like why I put the tourniquet on a certain way, or what the reasons I used a certain pressure on the tourniquet. Because actually, like, residents and fellows would ask me, and I would say, like, well, this is what we do, right? So you can get caught into this, well, I prep it this way because that's how Dr. Goldfarb did it, right? And it's right because clearly somebody who has years of experience beyond you has been doing it, but until your own algorithm is populated by data that has been accumulated either through your experience or through your acquisition of knowledge, like reading papers, reading chapters, reading books, etc., it's not really your algorithm and your intuition. And for example, like those of us that are not full professors yet, like Dr. Goldfarb, we still have to take trauma call. And I actually really enjoy taking trauma call because I get to work with the residents and I love doing general orthopedics and fixing long bones and all that kind of stuff. But we're prepping for a femoral shaft fracture. And I said, well, why did you prep it this way? And they're like, well, that's how Dr. So-and-so did it. Does it. One of the trauma faculty. I was like, all right, man, I totally understand that. But why? And they're like, well, that's how Dr. So-and-so does it. I'm like, wait, but let's think about this. And I think that that's nothing against that resident because that's, what they have learned. But eventually at some point you have to step into it, take some ownership and really understand why you do what you do.
Yeah, and getting back to your original question, like how much of my, responsiveness is based on intuition, I would say the vast majority of it is because I will also know when intuition doesn't help me. And if I don't feel like I have an intuitive response, I'm old enough that even to a patient, I can say, I need to think about this. I need to get back to you. I need to do some research on it. I think we should all be comfortable saying things like that. But it's harder when you're young because you don't want to affect that doctor-patient relationship. Old people like me get the benefit of the doubt when I say, well, this is new to me, or this is different than I've seen before. I'm getting a little off target, but that's how I think about it. It's intuitive till it's not. And I think the danger is if you just have a knee-jerk reaction to everything, that's not right either.
Yeah, no, I think that the one way of summarizing that is, you don't know what you don't know. And then like you're saying, your intuition and your algorithm gets you so far. But if you don't know when to stop and to pause and say, gosh, this doesn't quite add up to, the vast majority of situations I've seen. If you don't know when to hit that pause button, you're going to get in trouble. And it is hard as a younger surgeon and probably a younger therapist to tell patients like, you know what, this doesn't look quite right. I need to talk to somebody else. And I love being able to say, you know what, I need to talk to somebody with grayer hair or less hair than I do. That makes people chuckle. But I've found as somebody who is still young and young looking, if you tell patients like, look, I've done a number of these, I've done, you just don't fit everything, and I want to make sure we get it right for you. there's a way to frame that so that personalization helps them understand, well, this person really knows what they're doing. But if you just say, I don't know what's going on here, I got to talk to some people, I'll get back to you, that's not going to rub anybody the right way.
Yeah, and the first thing you said about saying it correctly, if the patient doesn't like that, let them move on. Let
Yeah.
them go to a different doctor. Let them go to a different therapist, because that's not going to work out well for you. Yeah, I love that. I love number 4 too, which is limit the drain of decision fatigue. And basically, it says we all make hundreds of decisions a day. But what is so great about what we do is that we're trying not to make decisions, right? So the more we have a protocol, the more we have the way I do it, then fewer decisions are made, so that when we have to make an important decision in surgery, in clinic, we are ready to make that decision. And I don't think I come home tired at the end of the day because of decision fatigue. I come home tired for other reasons, but I don't think it's decision fatigue, because so much of my life and my approach to problems is based on what I consider protocols.
Well, you don't have decision fatigue because you wear scrubs every day to work and you don't eat lunch. So you don't have to pick what to wear. You don't have to pick what you're going to eat for lunch. So you're fine. You're just tired and hungry and dehydrated and whatever. But you look good. No, I agree with you. I think having protocols is incredibly helpful. Again, like we kind of talked about in the last session, is just making sure that you know when to deviate from the protocol, when somebody deserves, when the situation is different than what you normally seen or encountered.
Yeah, I can't say any better than that. And I don't know there's much else. I mean, we all make decisions every day. I think that's part of our training and part of our experience. Again, these are not necessarily business decisions, but that's just part of healthcare. So that one, I think, resonates for the reasons we have said, but maybe not too much beyond that.
And so the last one is to construct creative constraints. And it says here, you may be familiar with Parkinson's law, which states that work expands to the time we allow it. So put simply, if you give yourself 1 month to create a presentation, it will take you 1 full month to finish it. But if you give yourself a week, you'd finish the same presentation in a shorter time. Has that been something that you have used to shorten the amount of time it takes to get something done?
For me, it's not about the amount of time something I give myself to do it, which I think I'm saying the same thing, but basically it's the deadline. And I think a lot of us function in this fashion. And I have a list of deadlines on my computer now. And if the deadline's April 14th or the presentation's April 14th, then there's some truth to the fact that I'm not going to get it done, especially with PowerPoint as opposed to the old school slides. I get it done before it's due. I have made an effort, especially when everything comes in ebbs and cycles and flows, and so I do try to shoot for an earlier deadline, at least mentally, so that I get that talk done a couple weeks in advance. But absolutely, we all function that way.
Did you notice how the allotted time for a Journal of Hand Surgery article review magically went down from like a month to 2 weeks? And I don't think it changed my management at all, because I was always doing it the day before or the day after or 3 days after. Sorry, Jennifer Wolf. But I was like, that's brilliant on their part. Just like change the deadline, because it doesn't really matter to me. I'm just going to do it at the deadline.
It's 100% true. I mean, that's the easiest and best example. We
And I think
function on
that
deadlines. I'm sorry.
Yeah, but to get back to their original point of Parkinson's law, like I think that that's really important for things that are more academic in terms of like writing papers or whatever. So like if you're trying to get a manuscript draft done and you've got a bit of writer's block, like all of us do, give yourself an hour, give yourself 2 hours, or if you're lucky enough to have the protected time, an afternoon to write a grant and get as far as you can. And because you will get just put some stuff down on paper, because if you spend the time procrastinating, etc., you're just going to end up kicking it down the curb and doing it another day because you ended up checking your email for 4 hours. So I've found that Parkinson's law really does apply to things that are I don't know, more along the academic or sometimes creative aspects.
Yeah, you know, I run into trouble where I just get objective in my task completion. And certain things are amenable to that. And much of my life is amenable to that. But the great example is writing a grant, which is what I'm doing currently, or really putting some thought into a manuscript. And you have to protect time, and you have to be as aware of your own self limitations and try to, we're kind of saying the opposite. I mean, we really just, you need to give yourself time to do what you need to do from a mental processing standpoint and get out of the check the box, see the patient, do the surgery, go home, have dinner, go to bed, do it all over again. And that's the joy, I think, in your life and my life, is when we can protect time for the thinking aspect of what we do.
Yeah, and I would I'd agree with that. I think that, this is, I think maybe we cover this in a different podcast, but this concept of protecting time for deep work, for the things that really require your intellectual horsepower, is super important. And that may not be as relevant to people that aren't in a setting where they're writing grants or writing papers, but for many of those listening, that's something you may have to do one day. So there's one time related thing that kind of weaves across the different bullet points that she mentions here. And one thing I've started to do in surgery, and I don't know if it's, it's a little creative, I think, is giving myself time limits on certain steps of the surgery. So say, like, I don't know exactly how this would relate to your world, maybe like the amount of time to do the osteoclasis or whatever. But if you're doing something that is tedious and a bit challenging, like for me, it's like when I'm carving out a nerve from scar or trying to find a ruptured nerve, and you're struggling at times and you may have to change tactics several times, saying, all right, I'm going to try this technique or this thing for 5 or 10 minutes. And in the OR, you lose complete track of time. So I actually have a very kind circulator set a timer and say, can you tell me when it's been 5 minutes? Because if I have not done this particular thing in 5 minutes, I need to move on, because I only have a certain amount of time to do this. And clearly there are some steps where you are time unlimited. You have to get it right. But, when you have other options, you just can't keep perseverating and saying, maybe if I keep spreading in this direction, I'm going to magically find this nerve. So I've started to set timers and say, look, if I can't get this out in 5 or 10 minutes, I'm going to change tactics entirely.
That is super interesting. I don't do that, but I'll tell you what I do. And I would say that some surgeons who are labeled as inefficient don't do what you say, and they take as long as they perceive as necessary, no matter what. And some would laud that, and some would say that's crazy. But I think some people are labeled for complete unawareness of time. I think I'm on the other end of the spectrum. I'm hyper aware of time. I'm always asking about what case is this, what time is this case supposed to end? What time is my next case supposed to start? But I'll tell you why what you said resonated. When I'm working with fellows, I will say, you have 3 minutes or 5 minutes to get this done. And if it's not done, I'm going to take over, get this step done, and then hand it back to you. Or you have 2 passes with that K-wire, get it right, or we can't afford a third pass, not because of time usually, but because you got to take care of, the fracture. So I do put objective limits now on some of the things I do, like you say.
Well, one of the things, I think we've mentioned this before, one of the things that I like to do with our trainees, when I'm doing, for example, a case that I'm pretty sure I know how long it should take and how long certain steps should take, like a primary ulnar nerve transposition, I'll say, okay, you have 20 minutes on a tourniquet. Okay, next week you have 30 minutes on a tourniquet. And then I'm taking it over because I obviously want to move things along. Now, oftentimes they'll do well, and I'll just let them keep going. But I want them thinking, I need to get this done in a certain amount of time. And I tell them, I don't want you rushing. I don't want you to be sloppy. I want you to be intentional, and I want you to be safe. But I want you to realize we cannot dawdle here. This is not like, I'm going to take my time finding every little branch of the MABC. You should be able to get this out, get this done, have nerve exposed by this point. We should start moving the nerve by this point. And I hope they appreciate that. And then on a longer rotation, they get to see their progression over those. It's kind of like it's my own little way of doing the milestones with them. And with my comment earlier, I mean, I'm obviously going to get the job done however long it takes, but I do need those kind of mental checkpoints to say, this is or is not working. So for example, if I'm doing a revision ulnar nerve and I'm dissecting, I've found healthy nerve proximally, but I haven't yet found healthy nerve distally, but I'm dissecting in an antegrade fashion, getting that nerve out. And then I hit a patch of scar. I'll say, okay, I'm going to give myself 5 minutes to work through this area of scar. And if not, I'm going to change tactics. I'm going to go find the healthy nerve distally and then work the other direction. And then I'm obviously going to have to go back proximally later on, but it just keeps me, I think, engaged and aware of how long things are taking.
No, I got it the first time you said it, and I think it makes total sense. I didn't mean to, I hope I didn't sound dismissive or anything,
Oh,
but
no, 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 no. I just wanted to make sure that anybody listening who didn't understand the concept was.
no, love it. And I enjoyed talking about this article. I think it's as you said when we started, I think both of us love this. I wish I had more time for HBR articles, but we will continue to sprinkle these in, I think, as we move forward.
All right, great. Well, thank you to everybody for listening. I will say we're going to have some more content on YouTube. All of the What's New in Hand Surgery content will be out there if you want to see what a quote live taping of this looks like.
Maybe you
Because
don't.
yeah, maybe you don't. There isn't much editing going on because Chuck does it all on his own. So
All right. Have a good day. Enjoy the weather.
yes, enjoy the weather. Take care.